Thank you, Delhi Ophthalmological Society, for
Sir, Dr.
this
Grover, sir,
opportunity to
the
be a
next
part
speaker.
of this beautiful session. I'm going to talk about the difficult area of medial canthus. Trauma to medial canthus, because of its complex structures, is a nightmare, both for primary management and more so for traumatic deformities. Today, I'm going to talk about management of the post trauma deformities. Now, the structures that are present in the region of medial canthus include the various bones, the orbital fat, the muscles, the vessels, ethmoid arteries, and the nerves, the medial canthal attachments with the help of the ligaments, and the lacrimal system. So, you may have trauma involving any of these structures. But many of the deformities are caused by injuries to the medial canthal tendon. Of course, there is this lacrimal apparatus, the fat, and the muscles, as we spoke about. The medial canthal tendon has a complex structure with a deep head or deep insertion and a superficial insertion. The superficial insertion is relatively easier to manage, but it is the complex posterior injuries which affect the posterior ligament, which cause the worst forms of telecanthus, which are attached behind the sac at the posterior lacrimal crest, which are more difficult to manage. So, naso-orbitoethmoid fractures occur usually due to blunt trauma or as a part of pan-facial trauma. Imaging helps identify the structures involved, and there are special techniques for the medial canthal region. So, these injuries to the tendon which cause traumatic deformities are either those which involve the anterior or posterior crus of the medial canthal tendon, or the associated fracture with their various conformations. Now, an anterior crus injury, as I said, is relatively easy and it can be sutured to periosteum anteriorly at the anterior lacrimal crest. But the posterior crus is more difficult to manage. You need a careful restoration with permanent sutures like Prolene in primary trauma, but in complete avulsion, you may require microplating, as we'll talk about later. So, an avulsion like this can be reposed, but most cases also have a canalicular trauma, and that needs to be tackled as well. So, fortunately, we are blessed with a very rich vascular supply on the face, and avulsions like this, if sutured well, give us results that are very gratifying. But when the deformities occur, they may be either due to the soft tissue injuries, which is primarily because of the ligament, or the naso-orbitoethmoid fractures. Soft tissue deformities again require a variety of techniques, like the one that we see here, a Z-plasty. So, the principle of medial canthal repositioning is restoration of the medial canthus behind the sac at the posterior lacrimal crest. So, you have to identify the region behind the sac, put a suture through that, and use that permanent suture with periosteal bites or through whatever means that are required to anchor it to the medial canthal tendon. So, once this is done, it is anchored to the medial canthal tendon, and then the restoration of the medial canthus is done, restoring the right position. So, this is an example of a posterior fixation of medial canthal tendon, which combined use of a Y to V plasty in order to reposition the medial canthus. So, you can see a medial canthus which is grossly displaced being put back in position and the depth being restored. When there is a downward displacement like this, it is best to do a Z plasty or a Z plasty in order to get the canthus to reposition, taking the medial canthus in the lower limb and then transferring it upwards in order to get a much better position of the canthus, as you can see here. So, this is an example of a beer injury with a forehead scar with a traumatic telecanthus, anteriorly displaced canthus, where we decided to do a scar revision, repositioning of the medial canthus deeply, and at the same time taking care of the scar. So, this is how it looks from this anteriorly displaced canthus to a corrected telecanthus, and the scar has been repositioned. The brow, which was malpositioned, has been put back in position. The bony deformities require a different kind of strategy. You often need to refracture, realign, sometimes do a bone graft. So this is an example of a bone graft and nasal wiring. Other internal fixation techniques, the most preferred one is low profile mini plates, which we often use. Plates like these are anchored to the posterior lacrimal crest, one of these holes being used with a proline thread to anchor it to medial canthus. So an example is this kind of a patient where we'll do a Y to B plasty along with the medial canthal repositioning using a mini plate made of titanium fixed with screws. So this is a double hole titanium plate where we are fixing it with self-drilling screws. Generally, short screws only can be fixed here. The other eye has 40 proline suture, which is then passed through the medial canthal tendon, and once this is realigned, it gives you a dramatically improved position, as you can see here. This grossly displaced medial canthus can be repositioned. This is the example of an early post-op appearance, pre and post-op appearance, where you have a gross deformity, you are able to improve it, and then day one, this is what you see, and when you have done the ptosis correction as well, you can restore this to a much better position. So when you have a bilateral one like this, transnasal wiring is often the answer. She had a bilateral nasolacrimal duct obstruction as well, so we did an open sky DCR and transnasal wiring. We could really transform her life with a much improved lid position. You can see how it would change her life forever. So thank you for this opportunity again. The traumatic deformities of medial canthus are a tough problem, but with perseverance and with proper technique, they can all be tackled. Thank you.
So, Professor Titial is the next speaker, and then I'll go next.
Thank you so much for a wonderful presentation, sir.
Good.
Such complicated cases made so simple.
Dr.
And
Grover's
so thank
surgery
you, sir.
always is a treat to watch, sir. Bloodless and super clean.
Edited versions are bloodless.
Sir, इतना blood तो नहीं दिखता वैसे भी.
And thank you
Very
for
clean
letting me
surgery.
speak first, both Dr. Tyal